Welcome everyone to the Incident to Questions and Answers webinar. My name is Ellen Vera and I'm a specialist with our Provider Outreach and Education Department. With me on the call today is Mary Muko, my friend and colleague, who's going to be taking care of our chat function for us. She'll be answering or asking any questions that we have at the end of the presentation. The first thing that we have is our disclaimer statement. We have prepared this education as a tool for you to use. However, if you've been with Medicare any length of time, you know that Medicare rules can change often. The CMS rules and regulations are the final determinant of coverage. We will provide responses to your questions, but again, the Medicare rules determine actual coverage of services. CMS does prohibit recording of the presentation for profit-making purposes. So if you are doing screenshots or recording, we do ask you not to do that. We are recording this presentation and it will be available both on our website, under our training center, under Encores, and also will be available on our YouTube channel. Here are just some of the acronyms that we're going to be talking about today. I like to gather them all up in one spot, so if you need to go back and reference one, they're all there for you. Oh, wrong way. So here's what we're going to do today. This presentation is designed as a question and answer presentation. So we're going to do a brief overview of Incident to services and the Incident to requirements by CMS, how you bill for those, what you need to have in your documentation, etc. So after we provide that brief overview, then we will open it up to any of the questions that you have. Now, we did have one pre-submitted question that stated what to include in surgery procedure and anesthesia units. I'm not for sure how this relates to Incident to. So if you submitted that question, please submit that in the chat and then kind of give me some more information as to how that applies to Incident to services. So when we're looking at the definition of Incident to, basically what this means is that the billing provider, the person who puts their NPI number, their provider transactional access number on the claim form, is not the person who actually did the service. And Medicare has rules as to when you can bill in those particular circumstances. So the service then was either provided by ancillary staff or your clinical nursing staff or by a non-physician practitioner. Now, a non-physician practitioner can be incident to a physician. Ancillary staff can be incident to both the physician or to the non-physician practitioner themselves. So what are some of the requirements then for Incident to? Well, it has to be part of that billing practitioner's care of that patient. So what we mean by that is that that billing practitioner, we'll call that person Dr. Smith today. Dr. Smith is that person's provider. They're the physician that that patient is going to in order to receive their care. However, as part of that care, that provider has a care plan in place, and then either the ancillary staff or the non-physician practitioners are following then that care plan. There has to be an employment relationship between the person actually providing the service and then that billing practitioner. Now, that employment relationship can be a W-2 employee, meaning that that person is a direct employee of the person who is billing. It could be that both parties are part of the same group, and so the group employs both the physician or the non-physician practitioner and then either the non-physician practitioner or that ancillary staff. It could also be a contracted employee. It could be a leased employee. So should Medicare request it, what we would need to see is that employment relationship, either the W-2, either the lease agreement, the contract, whatever you have in place. The next bullet point, commonly rendered without charge or included as part of that professional service. So what we're talking about there is that the billing practitioner is the one who's going to bill for that service. The patient expects that that billing practitioner or that clinic or office is going to be billing them for that service. It's things that are part of that physician or that non-physician practitioner's, their normal provision of services to that patient. Commonly furnished in a physician's office. We have this on the next slide that we'll kind of talk about. Furnished under direct supervision. We'll talk about that in just a second. And then that last bullet point is also very important. The billing practitioner maintains involvement in the patient's care. So there's a couple of things that we're kind of talking about there. One is that if the patient goes in and they see the MD or the DO to begin with, and then that MD or that DO is transferring care to that non-physician practitioner, it's no longer an incident to service. That non-physician practitioner is now the one who's really taking care of and deciding the care plans for that patient. So what we're looking for in the documentation for that particular bullet point is the fact that that billing practitioner is still the one making the decisions for that patient. They are involved enough within that patient's care so that they know what is going on with that patient. They are aware of any issues or concerns that that patient has. They're not simply I'm starting care and now I'm going to turn it over to my NPP in order to actually take care of that patient. Incident to services can only be provided in a non-institutional setting. This includes office, and we have the 11 two-digit place of service code listed there for you, nursing facility, or a patient's home in specific circumstances, and we'll talk about that in just a minute. You'll notice here that nursing facility is listed. Now, this is not a skilled nursing facility, but simply a nursing home. And in order for Incident 2 to apply, all of the other things that we're talking about today have to also apply. Institutional settings, this is going to be your inpatient services. Incident 2 does not apply there. Outpatient hospital, which includes off-campus outpatient hospital, on-campus outpatient hospital, and emergency room. Incident 2 does not apply there. If the non-physician practitioner is the one providing the service, then that's who you'll bill under. If ancillary staff are providing that, then the ancillary staff services will go under that facility billing, not under the professional service. And then the same thing applies to a skilled nursing facility, which is place of service code 31. A skilled nursing facility for your patient is going to be when they are under Part A coverage. Now, a patient going into a skilled nursing facility, the skilled facility can actually be designated as a skilled nursing facility. But number one, the patient's condition may not meet the requirements for that. So even though they're in that skilled facility, they would be considered a nursing facility patient in that situation. You can also have situations where the patient is still meeting all of the Medicare guidelines for skilled nursing facility reimbursement, but that patient's benefits have exhausted. Medicare can allow up to 100 days in a benefit period for skilled nursing services. If the patient goes beyond that, then for your billing, you would bill as a nursing facility. So services provided under Incident 2 have to be supervised. So there's a couple of things that go along with this. The key to the supervision is immediate assistance. If the practitioner or the ancillary staff, if something happens with that patient, the practitioner who's billing for that has to be able to respond immediately. Now, immediately, as it's defined, is pretty much right now. We need something, the patient has fallen out, they're having an allergic reaction, they're having something happen, and so therefore there needs to be that immediate response. In an office setting, this is going to be where that person is in the same office suite as the person who is rendering the service. So if you think about that for a minute, especially nowadays, we have lots of locations where there's multiple physicians' offices within that building. However, when you look on the door that goes into all of these, little additional offices, it's identified as Dr. Smith's or ABC Clinic or whatever it might be. The supervising physician, if you're providing that supervision in person, needs to be within those particular offices. If they're down the hall talking to somebody else, they're really not within that same office suite. You can also see there that we have speaking loudly distance. This one is going to apply more in your nursing facilities than within your office suite, because they are going to be there within the office suite. Speaking loudly distance, this is a term that was used by a former contractor medical director that worked for WPS. And he said that that person who is providing the supervision, you need to be able to get to them right now, not shouting, not by telephone, anything along those lines. It can be the supervising practitioner can be someone different than the treating practitioner. So let's talk about that one for a second. Let's say that the patient is a patient of Dr. Smith's, and the nurse practitioner is seeing the patient today under the Incident 2 guidelines, but Dr. Smith is not in the office today, but Dr. Brown is. Dr. Brown can provide that supervision, and Dr. Brown then would be the one who would bill for that service today, as long as, again, all the Incident 2 requirements are met. There is no requirement that that billing practitioner has to see the patient on the same day. Generally speaking, we get this question when we're dealing with ancillary staff, as opposed to the non-physician practitioners being the one to see the patient. You can also provide virtual supervision, and this is effective as of right now through December 31st of 2024. You'll want to pay attention to what CMS proposes in their proposed rule, and that should come out in July. And then what they determine is their final rule, which will come out at the end of November, as to whether or not this virtual supervision will continue through 2025 and beyond. Now, what we're talking about here is that the supervision is available through both audio and video communication. So the nurse practitioner, the ancillary staff, etc., they have to be able to both see and hear that supervising practitioner. Again, it has to be immediate assistance. So if you have to find them somewhere. They're not in a position where they can take that audio video communication right now, then that immediate assistance really is not valid. They don't have to be present in the same room. And so what I mean by that is that you don't have to have audio video communication equipment in each of the rooms where you're seeing patients. Just like regular supervision, that practitioner does not have to be present in that same room. However, you do have to be able to get a hold of them, and to get a hold of them right now should that patient need that assistance. So what we have provided for you next is resources. You have the Social Security Act there, you have the Code of Federal Regulations, you have information from the Internet Only Manual, and we have 2 sections listed there. We also have information from the Internet Only Manual 100-04, which talks about, it's kind of in the evaluation and management section. We have a national coverage determination about a physician's office within an institution. And what that's really talking about is a separately designated area for that physician or practitioner. It can't be the whole institution. It's going to be just that particular area. And then services within that area, if it's an actual office area, not an off-campus or on-campus outpatient service, then that can still fall under the Incident to guidelines. And then CMS also has information there in an MLN that you can take a look at. We have the MLN SE 1609, which is a policy clarification for prolonged drugs and biological infusions. You want to take a look at that if you're doing that type of service within your office. CMS has an Incident to services page, and then we provided you 2 resources there for allergy immunotherapy, which works a little bit differently. We've talked about for Incident to, the billing practitioner has to be the one responsible for that patient's care. For patients who are receiving the allergy immunotherapy, you can have an allergist who's not going to be the one supervising the nursing staff giving the allergy injections, and you can still bill for that. But the LCD, local coverage determination, and local coverage article will provide you with more information if you're doing those services. The next thing that we have before we go into questions is we wanted to let you know about a national provider enrollment conference that CMS and Noridian will host in San Diego. This will be on August 28th and August 29th. We're going to place into the chat for you the description, or a link rather, to the description and the registration. And then we also have this available on our website. What we have on your slide is a link. So if you have downloaded the presentation, then you'll be able to go into that also. But what this conference is really going to do is talk about all aspects of provider enrollment. So if this is something you're interested in, you can certainly sign up for this. So the next thing that we're going to do is go into questions. One of the pre-submitted questions that we had talks about documentation requirements. Well, what we need to have in the documentation is who's providing the service. So if Dr. Smith is the one who's billing, but your clinical staff, Nurse Susie, is the one who's doing the service, we need to have her information in there. We need to know what service it is that's being provided, and then how that fits into the plan of care. So if your practitioner, for an example, again, we'll go with Dr. Smith. If Dr. Smith has determined that the patient needs to come back once a month for the next 3 months to receive a B12 injection, that's his plan of care. So when that nursing staff then is doing that B12 injection, when they come back the following month, they're following that plan of care. Now, it gets a little trickier when you are using non-physician practitioners as the person who's providing that service incident to the physician. Non-physician practitioners can make medical decisions, obviously, for their patients. So what we need to see in that documentation is that that person is still following the plan of care from that physician who developed that plan. If the nurse practitioner or the non-physician practitioner changes the plan, then the service is no longer an incident. So if the non-physician practitioner changes that plan of care, then it's no longer an incident to service. Another question that we get, and we receive this one quite often, is do we really need to enroll our non-physician practitioners? They only provide incident to services. Well, number one, that's not an accurate statement because they don't always provide incident to services. And you always need to enroll your practitioners if they're eligible for enrollment with Medicare. So your non-physician practitioners, you do need to enroll. One of the ways that it kind of takes a service that you would think is going to be an incident to service is the oh, by the ways. Your patient is, coming in, you're following the plan of care of the physician, and, everything's going along just fine. Your nurse practitioner then turns and gets ready to leave the room, and the patient goes, oh, by the way, I have a rash on my elbow. When that non-physician practitioner then is taking care of that patient's rash, that is no longer an incident to service. And you would need to bill that under your non-physician practitioner's provider number rather than your MD or your DO. So that's why you need to have them enrolled. Another pre-submitted question that we have, and this one is a little complicated. The place of service is actually not 11, it is a 19, which is an off-campus outpatient hospital department, or a 22, which is an on-campus hospital outpatient department. Incident 2 does not apply there. So the question that the person submitted was the MD or the DO sees the patient for an evaluation and management service. The non-physician practitioner provides an injection into the joint. So what are the rules on this type of situation? Well, the first thing that you need to think about is, are both of these practitioners working together to provide a service to the patient? If they are, split shared guidelines apply in place of service 19 and 22. So if they're working together and, they're both treating whatever is, causing the need for the injection into the joint, they're probably doing a split shared service. And then in this case, they really need to look at, does the evaluation and management service, should it be billed separately? Can you include a modifier 25 on it, etc.? If they're not working together, not providing kind of a single service to that patient, a non-physician practitioner is a different specialty than the MD or the DO, so then that service could be billed separately. Another pre-submitted question that we had is, does incident 2 apply in the home? And the answer to that is yes, if the billing practitioner is present in the home. So if the doctor takes the nurse with them to give an injection or whatever, then the doctor can still bill for that injection. There are some other qualifications or requirements that can be met if the practitioner is not in the home. One of those is that the patient does have to be homebound, and there is no home health agency in the local area to provide the service. I'm going to give you a reference, and it's the Internet Only Manual 100-02, Chapter 15, Section 60.4, and all of the subsections in that section that will provide you with what the requirements are for Incident to services in the patient's home. Another pre-submitted question that we had is standard protocols. Now, we want to think about standard protocols a little bit anyway, because all services have to be medically necessary for the patient. The documentation has to show why you're doing whatever service it is that you're doing for that particular patient. Why is it reasonable and necessary? If your documentation shows that, then Incident to requirements can apply as long as all of the Incident to information is in the documentation. So what I mean by that, let me say that a different way also. So your patient's plan of care, your MD or your DO says again, B12 shots once a month for the next 3 months. Well, then you get to month 4 and the patient comes back in and the nurse also gives a B12 injection based on, just their standard processing. That would not fall under the Incident to, because the plan of care said 3 months. So you want to take a look at who's providing the service, why are they providing the service, where is that notated within the physician or the non-physician practitioner's plan of care. So Mary, let's go ahead and open it up for questions then.
Hi, Ellen. The only question that we have received thus far is whether or not the supervising physician needs to sign off on the chart note.
The information that has been published by CMS is that physicians or non-physician practitioners, for that matter, are responsible for the information that is submitted under their name. So we actually sent this question to CMS, and they did publish and update a signature requirement MLN, and I don't have that number right off the top of my head, but I'll tell you how to get there in just a second. But they did indicate in there that providers should be signing the information that is being billed under their name. So both an Internet Only Manual reference has been updated, and then also the MLN. If you go into the CMS website, which is cms.gov, go over to the right-hand side of the screen where it says Training and Education. Then you go to the left-hand side of the screen and it will say Publications. Once you hit Publications, the first thing that comes up will be MLN. Hit that one or click on that one, and then you can do a search and just do signature, and it's called a filter rather than a search, but do signature, and then that new or that updated MLN will come up for you. Any additional questions, Mary?
No, Ellen, and I have to apologize because I did send out a response to that question saying that there is no need to sign off on the chart, but I honestly was not aware of this new CMS publication. So you can disregard the information that I published at 2:26. What I said was there does need to be evidence in the record that all incident to criteria was met. And that's what CMS previously,
Yes.
had us respond. So I have to say that I learned something new today, and I want to thank you, Ellen. I am looking for that updated MLN so that I can drop that into the chat. But if we don't get it into there, if I don't find it before we conclude today, we'll get it out to everybody. And so I
Yeah.
just wanted to make certain that everybody understands that there was a change there. We do have a couple of more questions. Ellen, is
Sure.
a plan of care required for incident to services that are wellness services such as an AWV provided by a clinical pharmacist?
Okay, the annual wellness visit is, and some of those things are a little bit of a different animal. You can have an annual wellness visit that is provided by a group of healthcare professionals, but it has to be under the direct supervision of that physician, an MD or DO, not the non-physician practitioner. And so in the question, can a pharmacist be part of providing the annual wellness visit? And that would be incident to that billing practitioner. The answer to that is yes.
Thank you. The next question. Medicare views providers as the two-digit specialty under which they are enrolled with Medicare. Does this also hold true for Medicare Advantage plans?
I really can't answer for Medicare Advantage. I would make an assumption that it holds true, but I don't know that for sure. You'll need to talk to the plan.
All right. The next question is, does the billing provider need to create the plan of care? Or can an NPP create a plan of care and then have the provider sign off and approve it? Specifically regarding CCM, which is chronic care management.
When we're talking incident to services, the billing practitioner is the one who has to have created the plan. Now, I'm going to set aside chronic care management just for a second because that's, again, kind of a different animal. So when we're talking incident to in the regular incident to guidelines, Dr. Smith is the one treating that patient. Dr. Smith is developing the plan of care, and then everybody else is following that plan of care, whether it's the non-physician practitioner, whether it's ancillary staff, etc. Now, chronic care management, the non-physician practitioner can also bill for chronic care management um, when chronic care management is being provided by the ancillary staff. So chronic care management, and we have information, in fact, we have a whole playlist with about 24, I think 24 different videos on our YouTube channel on chronic care management. So if the nurse practitioner, for an example, is the one who is developing that plan of care, then that nurse practitioner can bill for the chronic care management services that are being provided by the ancillary staff. In the question that was asked, can the non-physician practitioner develop that plan and then bill under the physician, the MD or the DO? The question that I would have to you is kind of why are you kind of going in that route? For chronic care management, while the physician does not have to develop the entire plan for chronic care management, they do have to be directly involved in developing that plan. And it's not just I'm going to sign off on this, whether that plan has input from the MPP or from the ancillary staff or the clinical staff. So I would encourage you to take a look at the videos that we have out there on chronic care management, the incident to guidelines, because it is general supervision as opposed to direct supervision, do work a little different. Specifically to your question, if your NPP has totally developed that plan of care, then bill your CCM services under your NPP.
All right, we have one more question that's come in. Ellen, can you bill for a service provided by a dietitian when the code says it has to be provided by a physician or other specific providers, but a dietitian is not listed?
It's going to depend on the individual service that you're talking about. We have some services, such as diabetes self-management training, that there's kind of an incident to provision in there, although it's not an actual incident to service. If your definition of your procedure code indicates medical professional only or physician only is another way that I have seen that, then unless CMS comes back and says you can specifically, then no, it would have to be done by that MD or DO. You want to look at how that code is actually written in the CPT, and then look for any exceptions that CMS may have.
Ellen, there are no further questions at this time.
Okay. So on behalf of Mary and myself, we do want to thank you for your attendance today. Incident 2 can be sometimes a confusing topic. However, we did want to be sure and respond to all of your questions. We do, again, encourage you to complete this survey. We really are interested in your feedback. Not only does the survey responses go to CMS, but we use those in developing our education. So we want to thank you very much for your attendance today, and you can now disconnect.